Hello, testing, testing. So I'm delighted to introduce our own little Hayley. Woo, Hayley Burns. Grew up in Pittsburgh. We're not going to hold it against her that she went to Ohio State for college. I refuse to hold it against her. She went to SLU for medical school, and we were so fortunate to recruit her here to our residency program. And she has been accepted at one of the premier urogynecology fellowship programs at Loyola in Chicago. And the topic she has chosen is just, I am just dying to hear this talk. And it involves the ethical issues with vesico-vaginal fishes. Go ahead, Hayley. Yeah.
Woo! All right. Is this loud enough? Can you guys hear me? Okay, perfect. I've never used this TED Talk microphone before. So good morning, everyone. Thank you, Dr. Rice, for the introduction. I have been really looking forward to talking to you about the ethics and sort of the history around the cure of the vesico-vaginal fistula. And I'm going to refer to my notes because I have a lot of quotes to read, and I could not memorize all of the quotes written, in the 1800s. So I have no disclosures. So I would be willing to bet that many of you in this room do not know who this man is, despite his nickname as the father of gynecology. His name is J. Marion Sims. I actually was unaware of the work of Dr. Sims until I attended the keynote lecture at the American Urogynecologic Society's annual meeting this fall that was given in his honor. At that time, I was desperately searching for a topic on which to give grand rounds. And as the lecture progressed, and per Dr. Brown's advice, which has never steered me wrong, I decided that I would present the controversy of his work in the hopes that I could share with you a piece of history that has vividly shaped our field today. So I first just wanted to briefly review medical ethics before I dive into the life, the work, the controversy, and the impact of Dr. Sims. So the English physician and philosopher, Dr. Thomas Percival, who is pictured here, is credited with coining the term medical ethics. And in 1803, he published a modern code of ethics that is said to have asserted the moral authority and independence of physician in the service to others, affirmed the profession's responsibility to the care of the sick, and emphasized individual honor. In its infancy, the American Medical Association adopted its own code of ethics, which was influenced by Percival's work and the well-known Hippocratic Oath. Since its adoption, the AMA Code of Medical Ethics has been revised multiple times, and today it includes the well-known principles of beneficence, autonomy, non-maleficence, and justice. These four principles are the foundations of what we consider principle-based ethics. Beneficence is the action that is done to benefit others. It is suggestive of altruism, love, humanity, and promoting good. Non-maleficence is the principle of doing no harm. Autonomy is viewing the rights of the patient, and justice represents the idea that the burdens and benefits of new or experimental treatments must be distributed equally among all groups in our society. In OB-GYN, there often exists huge discrepancies between patient autonomy and the principles of beneficence and non-maleficence. The last ethical principle that I wanted to talk about is that of informed consent. And we've discussed multiple times at M&M that having a patient sign a consent form does not mean that consent was obtained. By definition, consent is the willing acceptance of a medical intervention by a patient after adequate disclosure by the physician of the nature of the intervention and the risks and benefits of the intervention, as well as alternatives along with their risks and benefits. The most important element in obtaining consent is ensuring that the patient really has capacity to provide consent. And a patient's capacity can be influenced by their maturity, the state of consciousness of the patient, mental acuity, education, their cultural background and native language, as well as the patient's opportunity and willingness to ask questions. In looking at this, I found a statistic that almost half of all United States adults read at or below the 8th grade level. As such, it's suggested that when we do our consent forms, we write them at least 3 grade levels lower than the average education level of our target population. Finally, consent must be voluntary, and the consent process should be free of coercion, pressure, or undue influence. So now we're going to switch gears and talk a little bit about the historical origins of gynecology and how Dr. Sims influenced our field. So in the first half of the 19th century, gynecology was in a very sad state. And in fact, the term gynecology really wasn't introduced until 1847. In American medical schools, the practice of examining female organs was considered very distasteful by most medical students who were at that time were almost all males. And obstetrics and child delivery was taught by the use of dummies. Often it was not until a doctor was in practice that he actually delivered a baby. And to quote, young doctors rarely had any clinical training in what the theory of birth meant in practice. Many arrived at a birth with only lectures and book learning to guide them. If they and the laboring patient were fortunate, they had an older, experienced doctor or attending woman to explain what was natural and what wasn't. Many young men were embarrassed, confused, and frightened by the appearance of labor and birth. American and European values affected access to medical care for gynecologic or obstetrical problems. Another example is that doctors often performed pelvic examinations while looking directly into the eyes of the patient, as nudity and exposure of the female body, even to the eyes of a doctor, was prohibited. Now, at the time of his death in 1883, Dr. Sims was considered the best-known physician in America. Many consider him, as I mentioned, to be the father of gynecology. Sims was born in South Carolina. He was the son of a county sheriff. He received his medical training at Jefferson Medical College in Philadelphia and returned to Lancaster, South Carolina, right out of medical school to practice. At the time of his graduation, he stated, "I felt absolutely incompetent to assume the duties of a practitioner. When I graduated, I presume I could have gone into the dissecting room and cut down upon any artery and put ligature around it, but I knew nothing at all about the practice of medicine. I had no clinical advantages, no hospital experience, and had seen nothing of sickness." In Lancaster, his first 2 patients, both children, passed away from cholera under his care. Discouraged, he left Lancaster and moved to Mount Meigs, Alabama, which is approximately 20 miles from Montgomery. It was in Mount Meigs that Dr. Sims had his first case of importance, a patient who had been seen by 7 or 8 doctors and was cured by none of them. Dr. Sims diagnosed an abdominal abscess and was bold enough to open it, drain the pus, and the man recovered. On the 13th day of December, in 1840, Dr. Sims moved to Montgomery, Alabama. He says, "The year 1840 was a memorable era in my life, and seemed to be a turning point in my career. For the first 5 years of my professional life, from 1835 to 1840, I was willing to turn aside to do anything to make money. But when I moved to Montgomery, I gave away my dog, I sold my gun, and I've never loaded or fired a gun since. I devoted myself to my profession, determining to succeed if industry and application could command success. I had an ambition for surgery, general surgery, and was performing all sorts of beautiful and brilliant operations. This was before the days of general anesthesia, and I had made, in 5 or 6 years, a reputation for surgery such that people came to me from all parts of the state." In 1950, so more recently, Seal Harris, whose father was a student of Sims, wrote Sims's biography, which is titled A Woman Surgeon. This book is actually available at eBling, and I would highly recommend that you check it out after I return it, of course. In this book, Sims claimed, "I never pretended to treat any of the diseases of women, and if any woman came to consult me on account of any functional derangement of the uterine system, I immediately replied, 'This is out of my line. I do not know anything about it practically, and I advise you to go to Dr. Henry or Dr. McWhorter.'" So I know you're all thinking, how did a man who was so passionate for general surgery become a gynecologist? Being married to a general surgeon, I can tell you that most want nothing to do with it. The Dr. Sims' interest in working into the field of gynecology was actually accidental. But before I tell you the story of that, I want to digress just a second and first discuss 19th century obstetrics. So in 1840, 1% of all pregnant women would die in pregnancy or childbirth. And at that time, as contraception was non-existent, most women had multiple children, making their lifetime risk of death approximately 1 in 8. At that time, there were no intravenous fluids, blood products, or uterotonics to treat postpartum hemorrhage. Antibiotics were not yet developed to combat puerperal infections, and no antihypertensives or antiepileptics were available for the treatment in preeclampsia. Treatment for obstructive labor was often expected management, as cesarean sections were deemed a maternal death sentence until the last part of the 19th century. After days of obstructive labor, heroic measures were often considered. These included internal versions and breech extractions, high forceps deliveries, or the most extreme, a method called lessening of the fetus, in which the impacted fetal head was destructed and the skull and other body parts were removed piecemeal. Vesico-Vaginal fistulas were most commonly described as tears that occurred during the childbirth process. However, in actuality, most 18th century obstetrical fistulas were a result of ischemic injury that occurred during obstructed labor. So when labor is obstructed, the fetal head becomes wedged deep in the pelvis, and contractions trap the head between the soft tissues of the bladder and the vagina between the fetal skull and the pelvic bones. As the force increases, urinary outflow eventually becomes obstructed, which leads to distension of the bladder and thinning of the bladder and more vulnerability to injury. At some point, the entrapped tissues lose blood supply and necrose. Labor would last for days before the fetus died, became macerated, and was passed from the pelvis. And then days to weeks later, sloughing would occur of the necrotic tissue and a fistula formed. Statistical data at this time period is scant, but there's evidence based on hospital records and medical writings that a significant amount of women suffered from vesico-vaginal fistulas. In the South, enslaved women were particularly vulnerable as they lacked proper nutrition, received no prenatal care, and had children at early ages before full development of the pelvis. Vesico-vaginal fistulas were not, however, just an ailment of the poor, for it was known that women of all socioeconomic backgrounds suffered from this condition. As we no longer see these types of injuries in the westernized world, we really can't appreciate the amount of destruction that can occur. In our country, most of the fistulas that we encounter are the result of post-surgical injury, which occurred to otherwise normal healthy tissue. And so the defects that we see are really small in size. In obstructed labor, however, the tissue damage can be drastic depending on the degree and the duration of impaction. In the most severe of cases, the entire bladder base can be lost, the urethra can be destroyed, and concurrent rectovaginal fistulas can occur. In addition to managing the continuous loss of urine, Patients had to endure significant pain resulting from their incontinence. With an acidic pH of approximately 6, constant urine exposure can cause vaginal inflammation, ulcerations, incrustation. It can lead to vaginal contractures. As described to the Georgia State Medical Association, the poor woman is now reduced to a condition of the most piteous description. Urine passing into the vagina as soon as it is secreted inflames and excoriates its mucosal lining, covering it with calcareous depositions and causing great suffering. It trickles constantly down her thighs, irritates the integument with its acrid qualities, keeps her clothing constantly soaked, and exhales without cessation its peculiar odor, unsupportive to her and those around her. She has been compelled to sit constantly on a chair or stool with a hole in its seat through which the urine descends into a vessel beneath. Later on, in describing patients with fistulas, Dr. Sims said, "The accident per se is never fatal, but it may well be imagined that a lady of keen sensibilities, so afflicted and excluded from all social enjoyment, would prefer death." In the early 1800s, no cure existed for the vesico-vaginal fistula, despite wholehearted attempts by the best surgeons. The first attempt was in 1675 by the Swiss doctor Johann Fadio, who used a swan quill to cut and fit the edges of the fistula tract together. This method proved unreliable and further attempts were unsuccessful. Dr. Johann Diefenbach, the pioneer of plastic surgery, claimed, "The cure of the vesico-vaginal fistula is one of the most difficult operations in surgery." Desperate for relief, women attempted to plug the defects with corks or fishing bobbers, which, as you can imagine, led to the development of very large bladder stones. Physicians recommended prolonged urinary drainage with antiquated urinary catheter devices that required patients to remain prone for 6 to 12 months with the device affixed to them. Other surgeons attempted cauterization of the fistula tract with silver nitrate or actual cautery. So getting back to Dr. Sims, he took care of men and women, wealthy and poor, free and enslaved patients in his Montgomery practice. And as I mentioned, he had made quite the name for himself, correcting cross eyes and clubbed feet. Patients were sent to him from all over the state for surgical ailments. As fate would have it, in 1845, Dr. Sims was asked to accompany a colleague of his to see a patient with obstructed labor. When he arrived, he found a 17-year-old enslaved woman who had labored for 72 hours. The fetal head was so impacted that labor had nearly ceased. Sims and his colleague delivered the patient via forceps. 5 days later, he was called back to see the patient for extensive sloughing of the pelvis. He stated, "Of course, aside from death, this was about the worst accident that could have happened to the poor young girl. I went to see her and found an enormous slough spreading from the posterior wall of the vagina and another thrown off from the anterior wall." He went home, searched his library for anything he could find on curing the patient's fistula before he deemed the case was hopelessly incurable. This patient's name was Anarcha. A month later, another slave owner came to see Sims, reporting that one of his servants, Betsy, had delivered a baby a month before and now was unable to hold a drop of water. Reluctantly, Sims replied that there was nothing that he could do for the woman. This owner was persistent, however, and sent Betsy to Montgomery to see Sims. When Sims examined her, he found the entire base of the bladder to be destroyed, and he sent her home with a note of his opinion of the case and of its incurability. Strangely, about a month after his second consult, he received yet another phone call of another woman, this time an 18-year-old slave named Lucy, who was also incontinent. Yet again, Sims claimed that this case was incurable. Weeks later, he was called to see a woman who was thrown from her horse, and he diagnosed this woman with an impacted uterus. Now, in the 19th century, when women needed a vaginal exam, they laid on their backs with their knees bent and their thighs apart. This woman, however, was of considerable size, and this position proved unhelpful. So Sims, recalling something he had heard in medical school, asked the patient to lie laterally, extend her bottom leg, and bring her top leg up towards her chest. In doing this, air rushed in, dilated her vagina, and he was able to see all of the anatomic relations. Realizing this important position, which we now call the Sims or lateral recumbent position, Sims became determined to re-examine those 3 patients that had vesico-vaginal fistulas. On his way home, he stopped at the hardware store and bought a pewter spoon. When he got home, he bent the spoon, placed one of the slaves in the knee-chest position, and wrote, "I saw everything and as no man had seen before. This fistula was as plain as a nose on the man's face." So thus began the next 4 years attempting to close the vesico-vaginal fistulas of the 3 enslaved women, Anarcha, Betsy, and Lucy. Sims practiced different techniques and utilized different suture material. With each failure, he refined his technique as well as his surgical instruments, including a makeshift catheter that he used to draw urine out of the bladder, keeping both the bladder and vaginal walls clean during and after the procedure. Leaders of the medical profession came from all around to his house to watch, excited to watch the infamous surgeon cure the incurable. However, over time, with each failure, they grew bored, and Sims was lucky if even medical students showed up to watch. When no one turned out to help, the patients themselves acted as Sims' assistants and contended with each other about who would undergo the next operation. Initially, Sims was using unsterilized silk suture for his repairs, given the tensile strength of silk. However, he noted that silk acted as an infectionitis, and over the summer of 1849, he heard of a Virginian surgeon using silver as suture. Knowing the antimicrobial properties of silver, Sims had his blacksmith produce a silver wire suture. And the application of silver wire suture fundamentally changed the way that vesico-vaginal fistulas were treated. Success came the summer of June of 1849 when he cured Anarcha during her 30th operation. He verified the efficacy and safety of the operation when he reproduced 2 more successful surgeries on Betsy and Lucy. He then began to operate on and cure women of all classes and races in Alabama, and in 1852, he published the book on the treatment of vesico-vaginal fistula. In total, he perfected his technique on 14 enslaved women. The technique that ultimately worked included placing the patient in the Sims knee-chest position, ensuring adequate visualization using the Sims speculum, vivifying the edges of the fistulous tract, ensuring a tension-free closure with silver suture, and prolonged bladder drainage postoperatively. Following his work in Alabama, Sims continued to make advancements in the field of women's health. In 1853, he moved to New York City, and he founded the first of its kind women's hospital in 1855. There, he continued to treat fistula patients and pioneered cancer care and fertility treatments, including insemination. In 1861, he moved to Europe, where he treated fistula patients in Paris, London, Dublin, and Brussels. He was asked to treat the Empress Eugenie of France, the wife of Napoleon III, for she was said to have suffered from a vesico-vaginal fistula. While in Europe, he made a name for himself as an internationally acclaimed surgeon. In the late 1860s, he returned to New York City and continued to care for women. During this time, he became known for his work in baddie surgery, which included performing oophorectomies to treat insanity and other disorders of the nerves. During the Franco-Prussian War in 1870 under Napoleon III, he treated wounded soldiers as part of the American Anglo Ambulance Corps. He was elected and served as president of the AMA from 1876 to 1877. And for the oncologists in the room, in 1883, he became instrumental in the establishment of the New York Cancer Hospital after arguing with the board of directors at his women's hospital over the admission of cancer patients. At this time, the board opposed admission because of the mistaken belief that cancer was contagious. In early 1884, a few months after he died, the cornerstone was laid for the New York Cancer Hospital's Astor Pavilion, which was dedicated to the treatment of cancer in women. It was the first of such hospital in the United States, and today, this cancer center is known as Memorial Sloan Kettering. Dr. Sims passed away in 1883 from a heart attack. A woman at his funeral said, "I never saw at a funeral such universal mourning. Old and young were in tears. One whole side of the church was occupied by medical societies. After the address, the congregation were invited to look upon him, once more the lid being removed from the coffin. The distress that manifested was extraordinary to behold. Men and women, old and young, rich and poor, wept as they gazed upon him. With some, it was actual wailing. I believe no man was ever more beloved." 11 years after his death, a bronze statue depicting Sims in his surgical robes was erected in New York's Bryant Park. This statue is currently located in New York City on 5th Avenue and 103rd Street, across from the New York Academy of Medicine. He was the first medical professional to have a statue in his honor in New York City. Other memorials were installed on the grounds of his alma mater, Jefferson Medical College, as well as at both the capitals of Alabama and South Carolina. The historical marker of his birthplace honors him for, quote, his service to suffering women, empress and slave alike. It is clear that Dr. Sims was a decorated, beloved American surgeon at his time. Throughout his career, he gave more than half of his time treating charity patients, and his career really led to the development of pelvic reconstructive surgery. As a matter of fact, for the past 37 years, the keynote lecture at the American Urogynecologic Society was named after him. So in light of everything I've talked about so far, you're probably wondering why the topic of my presentation is the ethical dilemma surrounding the cure of the vesico-vaginal fistula. On August 19th of this year, Sims' statue became the center of a series of protests. These protests came at a time when lawmakers were considering removal of Confederate statues in the wake of the violence that erupted in Charlottesville. Protesters claimed that Sims perfected his technique by carrying out a series of experimental operations on African-American slave women without using anesthesia. A lead activist stated, "At best, he was a man who recognized the humanity of Black slaves to use them for medical research about the human body, but not enough to recognize and treat their pain during surgery." Protesters were sprayed with red paint to signify women's pain after surgeries, and the group called for removal of the statue as it represented a deep, dark history and reproductive racism. While the recent protests may have received more attention from the media, the controversy of his work actually dates back much further. In the first half of the 20th century, Sims was considered a hero for advancing the medical care of women. But following the rise of the civil rights movement, his reputation began to change as critics questioned the ethics of his experimental operations. One author concluded, "His work was a classic example of the evils of slavery and the misuse of human subjects for medical research." In the 1970s, as Americans were dealing with issues of racism and sexual equality, historians began to paint a very different picture of Dr. Sims. And since then, his ethical standards of autonomy and benevolence have been questioned. To date, an abundance of literature has been published on the controversy surrounding his work. Googling his name produces nearly 1 million results. Most of these are criticism. The controversy of his work can be boiled down to 3 points: the lack of informed consent, failure to use anesthesia, and using slaves for medical experimentation. For the remainder of my presentation, I'm just going to take you through each point and talk about the views that his supporters and critics say of each. The issue of slaves being, by definition, unable to provide consent has been raised by many. Dr. Barker Benningfield wrote in 1974, "The women endured years of almost imaginable agonies, undergoing repeated surgery, and rather than being willing participants, they had been powerless to say no. The historian Washington stated that slaves did not have to be recruited, persuaded, and cajoled to endure pain and indignity. They could not refuse. One of Dr. Sims' strongest critics is Dr. Dorenda Ojenuga, who stated the enslaved women were not asked if they would agree to such an operation, as they were totally without any claims to decision-making about their bodies or any other aspect of their life. On the other hand, those who defend Sims claim that evidence would suggest the women strongly desired the surgeries, and he operated with their cooperation. In 1855, he wrote, "For the purpose of therapeutic surgical experimentation, I was fortunate in having 3 young healthy colored girls given to me by their owners in Alabama, I agreeing to perform no operation without the full consent of the patients, and never to perform any surgery that would, in my judgment, jeopardize life or produce greater mischief on the injured organs." He also wrote that at a time when he considered to stop attempting surgeries given his repeated failures, the women, quote, clamored for operations, insisting that he keep trying. Critics of Sims have deemed him an anesthetic racist, as he did not administer anesthesia to the enslaved patients, yet selectively used it for white women. Supporters of Sims claim that despite operating between 1845 and 1849, ether anesthesia was introduced in 1846, yet its acceptance was not universal, and there was strong opposition by surgeons to its adoption out of concerns for safety of their patients. Historian Martin Pernick wrote, "In the mid-19th century America, humane, conscientious, highly reputable practitioners and ordinary laypeople had many misgivings about the new discovery. Neither sadists nor fools, these critics alleged a variety of very rational drawbacks to the use of anesthesia. In addition, most 19th century surgeons, including the discoverer of chloroform, who was Sir James Young Simpson, said that repairing vesico-vaginal fistulas was not particularly painful. He quoted, "The mere amount of pain endured by the patient is perhaps less than in most surgical operations, as the walls of the vesico-vaginal fistula are far less sensitive than you would a priori imagine." Yet the take by other historians is very different, with one claiming that each surgical scene was a violent struggle between the slaves and the physicians, and each woman's body was a bloody battleground. Each naked, anesthetized slave woman had to be forcibly restrained by the other physicians through her shrieks of agony as Sims determinedly sliced and then sutured her genitalia. Ideology in medicine in the 19th century provided evidence that Black and white people were biologically distinct from each other, and that this difference manifested in different ways, including in pain tolerance. Seal Harris wrote, "Sims' experiments brought them physical pain. It is true. But they bore with it amazing patience and fortitude, a grim stoicism which may have been part of their racial endowment or which possibly had been bred into them through several generations of enforced submission." Finally, the ethics of using opium for postoperative pain control and quiescence of the bowel and bladder was called into question. A prior president of OGS, referring to the slaves, claimed that they were white man's property enslaved by opiates. And in the book From Midwives to Medicine, Deborah McGregor claimed, "Being habituated to opium is one further explanation for their acceptance of the situation." Lastly, supporters claim that Sims was a product of his time, and it is unfair to judge him on present-day standards. Erwin Kaiser wrote in the American Journal of OB-GYN, "It is easy to derogate Sims by applying 1975 social standards to 1850 decisions and conduct, but it is difficult to envision today the desperate state of an 1850 woman with total urinary incontinence, and it is against this background that the evaluation must be made." However, Dr. Ojenuga claimed that historical fact does not support his decisions, and that medical breakthroughs in the 19th century were achieved without the use of slaves. She cites 2 examples, the first being that of Ephraim McDowell performing the first laparotomy to perform an oophorectomy on a white woman with a 22-pound ovarian tumor. Prior to doing so, Dr. McDowell explained to this woman that the operation was an experiment, nothing more, but she accepted and proceeded with the surgery. The second case is of another physician who removed a tumor from a free white man's neck in 1842. He used ether. According to Seal Harris in Sims's biography, all kinds of whispers were beginning to circulate around town. Dark rumors that it was a terrible thing for Sims to be allowed to keep on using human beings as experimental animals for his unproved theories. This month, after 37 years, the J. Marion Sims Lecture was removed from the keynote lectureship series of the annual meeting of the American Urogynecologic Series, as it, quote, now serves primarily a source of polarization, pain, and disenfranchisement. While his legacy has been debated by many, Dr. J. Marion Sims is undoubtedly an important figure in medical history. As I am by no means a historian or an ethicist, I'm highly unqualified to take sides or have really an opinion of his work. I'm embarrassed to admit that I knew very little about him, and if nothing else, I've really enjoyed, as I hope you have, learning of his contributions to our field. Unquestionably, his legacy should be associated with experiments on a vulnerable population. And as some have previously suggested, that perhaps instead of toppling his statue, those of Anarcha, Betsy, and Lucy should be placed beside it. Dr. Spettel and White summarized nicely in the Journal of Urology, the ethics of surgical innovation, education, and experimentation are still relevant today. It behooves us as a profession to discuss, debate, or at least mention Dr. Sims' controversial legacy in our literature. Thank you. Thanks.
Okay, let's have some questions or comments. Does cause pause. I'm feeling pause here. Heidi, I'm looking at you. Yeah, I am. What do you think? Talked to Hayley about this talk, I was pretty much convinced that, I had an opinion, let's put it that way, and I'm now not as confident about my opinion as I was before the lecture, so thank you for that. Any thoughts or comments? Are we all just going to sit here in a moment of quietness? That could happen, which is also not wrong. Yes, Jenny.
Mm-hmm. Mm-hmm. Right. Mhm.
Thank you. Cynthia?